Javed Butler. I'm professor and chairman of the Department of Medicine at University of Mississippi. And I'm a cardiologist by training. My clinical career focused on heart failure, and my research career focused on heart failure clinical trials. You know, when EMPA-REG trial came out, heart failure was not a primary endpoint, was a secondary endpoint. And nobody was expecting that degree of robust benefit for heart failure that we saw. So several questions came up at that time. So the first question was, you know, is it just a fluke? Like, you know, maybe we just got lucky and can you replicate it? And then the second question came up is that the EMPA-REG trial had a combination of both people who had known heart failure at baseline, about 10-15% of the population, and about 80-85% of the population did not have heart failure at baseline. So the question is the heart failure data related to prevention of heart failure, or is it related to treatment of heart failure? So subsequently, over the next few years, you know, we got multiple cardiovascular outcomes trials that came out with dapagliflozin, with canagliflozin, with ertugliflozin, and while their other results may vary a little bit, what we saw consistently was the heart failure benefit across all the trials, and about the same, about 30% relative risk reduction. So basically, we answered one question, and that's not a fluke, it's replicated over and over again. But then it turns out that if you look at the data of people who had baseline heart failure and who did not have baseline heart failure, both groups of patients benefited. So in other words, you have also now proven that in patients with diabetes, you are preventing heart failure. The question is, if you are going to stick your neck out and say that we are actually treating heart failure, then we need really some more dedicated trials. And that's why we started doing the DAPA-HF, DELIVER, EMPA-REDUCE, EMPA-PRESERVE, more focused heart failure trials, not preventing heart failure in patients with diabetes, but treatment of heart failure itself. Now, one last point, what it also turned out that once we understood the mechanism of action of these drugs a little bit better, we started questioning, well, maybe these drugs will benefit people who don't even have diabetes. They do so many things in the body that may or may have nothing to do with diabetes. So the way the heart failure trials were being designed were to look at patients with or without diabetes. So while the drugs were first discovered as treatment for diabetes, the first trial that showed result, DAPA-HF and dapagliflozin, that trial showed that the benefit was almost the same in patients with or without diabetes. So they are more of cardiovascular drugs. So this is a super long-winded answer to your question. What are we looking for in EMPEROR? And that is basically to replicate the results of DAPA so that we are more comfortable that this is a result which is replicated, especially in patients who don't have diabetes, and that we can make it as a standard of care in heart failure with reduced ejection fraction. Yeah, so this issue sort of comes up, right? I mean, is dapagliflozin endocrinologist drug, primary care drug, cardiologist drug, or nephrologist drug? And I honestly think, I mean, this is like the patient's drug, right? So it doesn't matter where the patient's touch point is. I think we all have to take on the responsibility that the patient does not get a disease-modifying therapy, especially considering that many of these comorbidities tend to overlap. So it's a multi-organ system benefit in a lot of overlap in patients. So what I can say to my cardiologist friends is that it's probably, people will get used to a new class of drugs pretty easy. Like, I mean, we have done that in cardiology over and over again, that new classes of drugs were introduced. But at least, if there is reluctancy that I don't have self-efficacy to use this drug and I'm uncomfortable, then remember to prescribe it and work with your endocrinologists or primary care physicians who are more comfortable. So I think the first order of business is that somebody gives it and you create a partnership. But the second order is that we need to sort of create some pathways and education for cardiologists so that they feel comfortable using it themselves. So I won't know the answer precisely, and I would assume that the answer depends a lot on regional variation and insurance coverage and all that kind of stuff. But obviously, SGLT2 inhibitors are not generic, and neither is ARNI, valsartan, sacubitril, whereas other drugs like some of the beta blockers, some of the mineralocorticoid receptor antagonists and ACE inhibitors and ARB, they are generic. So there'll certainly be a cost difference, and those drugs will be cheaper, but what exactly is the cost difference, I don't know. It really depends on the region.